Okay.
Okay.
Good morning, everyone. And today I want to do a presentation about the multiple system atrophy. And I'll have 7 parts here. And multiple system atrophy is an adult onset and fatal neurodegenerative disease. It is characterized by the progressive autonomic failure and Parkinsonian features and cerebellar and the pyramidal features in various combinations. It is classified as 2 types, the Parkinsonian subtype and the cerebellar subtype. So the clinical presentations are variable. So sometimes the MSA may mistakenly diagnose as other disease, such as the Parkinson's disease, or some very difficult disease like the idiopathic late onset cerebellar ataxia. So first we'll talk about the epidemiology of the MSA. MSA is an orphan disease, which means it is very, very rare. The estimated mean incidence is about 0.6 to 0.7 cases per 100,000 person years. And the estimated point prevalence is about 3.4 to 4.9 cases per 100,000 person years. And among the persons older than 40 years, the prevalence increased to 7.8 per 100,000 person years. The cases of the Parkinsonian subtypes are more than the cases of the cerebellar subtype in most countries, with the ratio of 2 to 1 to 4 to 1. However, the cerebellar subtype is more frequent in Japan. So that might be related to the genetic or epigenetic factors. The disease onset is usually in the 6th decade of patient's life. Both sexes are equally affected, and the mean survival from the onset of motor symptoms is about 6 to 10 years, and with few patients surviving more than 15 years. So what causes MSA? There is no environmental factors have been associated with the increased risk of MSA. Like in Parkinson's disease, the nicotine use and alcohol consumptions are less common in MSA compared with the healthy controls. So the possibly representing a pathophysiology link among the alpha-synuclein diseases. But there are an association with agricultural employment and occupational exposure to the organic solvent, plastic monomers, and pesticides and mental dust has been reported. But these reports only in 2 case control studies. And the genetic factors play a role in some families. In a few European and Japanese families, the MSA has been transmitted in an autosomal dominant or recessive inheritance pattern. There are 3 genes correlated with the cause of MSA. The first one is the COQ2 gene. The loss of function mutation in the COQ2 gene was reported in Japanese families. And it is the only identified cause of monogenic MSA until now. But the mutation was not detected in patients from North America or Europe. And then the second one is SHC2 gene. The loss of copy numbers of SHC2 gene was found in monozygotic twins and Japanese patients with sporadic MSA, but also not tested in United States. And the third one is SNCA. The mutations, duplications, and triplications of SNCA gene may cause familial Parkinson's disease with features like the MSA in some members. Two single nucleotide polymorphisms of the SNCA locus shows a significant association with MSA in a large series of European patients. This association was confirmed in follow-up replication studies of MSA. And besides, a G55D SNCA mutation was recently reported in British families with autosomal dominant juvenile Parkinsonism and neuropathological findings compatible with both Parkinson's disease and MSA. And next, we'll talk about the neuropathologic features of MSA. In patients with MSA, variable degrees of olivopontocerebellar atrophy and striatonigral degeneration are typically found after patient's death when we do the post-mortem examination. Then we can see the three pictures from the picture one. We can see it's the olivopontocerebellar atrophy. It will cause the cerebellar syndrome such as the ataxia. And the second picture, we can see it's striatonigral degeneration. It will cause the poorly levodopa responsive Parkinsonism. And besides the third picture, we can see that the neurodegenerative changes will affect the central autonomic nerve system, such as the hypothalamus and dorsal nucleus of the vagus nerve and nucleus ambiguous, and so on. Then these will result to the multi-domain autonomic failure. And here we can see is the oligodendroglia cytoplasmic inclusions. This is the histologic characteristics of MSA, and the density of glial cytoplasmic inclusions probably reflects the distribution of neurodegenerative changes in the brains of patients with MSA, and the activated microglia and also the reactive asteroliosis are other common findings. And the main constitution of the gliocytoplasmic inclusions is the misfolded alpha-synuclein. And alpha-synuclein is a protein normally located in the neuronal axon and also in the synapses. The Parkinson's disease and dementia with Lewy bodies and pure autonomic failure are characterized by the neuronal alpha-synuclein aggregates. Therefore, the MSA, Parkinson's disease, dementia with Lewy bodies, and pure autonomic failures are classified as an oligodendroglia alpha-synuclein diseases. And next is the pathogenesis of MSA. So we can see from this picture, although the pathogenic mechanisms of MSA is still partially unclear, but the post-mortem examination of MSA patients show that it is a primary oligodendroglia lesion. So in the early stages of MSA, there is a protein named P25 alpha. It gathers and relocates in the oligodendrogliosoma. The P25 alpha is an important stabilizer to keep the myelin integrity. And then the oligodendrocyte becomes swelling. And then comes the abnormal uptake of the alpha-synuclein by the oligodendroglia, and also the overexpression of alpha-synuclein. The aggregates of P25 alpha precede the aggregation of alpha-synuclein, and there is also an interaction between the two proteins. And these will promote the aggregates of alpha-synuclein and then form a inclusion named the alpha-synuclein P25 alpha glial cytoplasmic inclusions is here. And the formation of the inclusions will hinder the neuronal trophic support and also induce the microglia activation here. The activated microglia will release some inflammatory mediators and also the oxygen reactive species. Then the dysfunctional oligodendrocytes will release the misfolded alpha-synuclein into the species. Then the neighboring healthy neurons will take this unfolded alpha-synuclein into their bodies to form a neuronal cytoplasmic inclusions. And then at this point, the neuron inflammation and loss of oligodendroglia neurotrophic support and also the neuronal dysfunction will due to the alpha-synuclein inclusions will promote the neuronal death and subsequent will reactive the asteroliosis. Then this toxic alpha-synuclein species then spread into other functional connected brain areas, then to lead to the multiple system neuronal involvement. So this is the typical of the multiple system atrophy. Next, let's talk about the clinical presentations. There will be three main presentations of MSA. The first one is autonomic failure. The orthostatic hypotension may indicate autonomic failure. The clinical diagnosis of probable MSA requires a reduction of systolic blood pressure by at least 30 mmHg at least, or diastolic blood pressure reducing by 15 mmHg after 3 minutes of standing from a recumbent position. And there will be also other autonomic dysfunctions like the genital urinary dysfunction, like the erectile dysfunction, urinary incontinence, and constipation. The second part is the Parkinsonism. Most MSA patients will develop Parkinsonism, such as the rigidity, tremor, or postural instability at some stage. The tremor is usually irregular, but the classic pill rolling rest tremor is uncommon in MSA. And the postural instability occurs earlier and progresses more rapidly in MSA compared with PD. And Parkinsonism usually responds poorly to the chronic levodopa therapy. However, there will be up to 30% of patients will show a clinical significant, but usually reducing response. And also there will be also the sleep disorders. The rapid eye movement sleep behavior disorder and obstructive sleep apnea occur frequently in MSA P type. The third presentation is the cerebellar ataxia. Like the ataxia of gait, the most common cerebellar feature of MSAC type, and is often accompanied by the ataxia of speech and cerebellar oculomotor dysfunction. Like Parkinson's disease, multiple system atrophy has a prodromal premotor phase in 20 to 75% of cases, including sexual dysfunction, urinary urge incontinence, or retention. Orthostatic hypotension and rapid eye movement sleep behavior disorder, months to years before the first motor system appear. And we should notice that the early and severe autonomic failure is a key feature of MSA. And multiple system atrophy is characterized by a relentless worsening of motor and non-motor symptoms during an average time frame about 10 years, and with more rapid progression at the first show up of the motor symptom. So here is the picture of the natural history of MSA. And the premotor phase of MSA can last for months to years. Here, year 0 means that the time of the start of motor symptoms. About 50 of patients will require walking aids within 3 years after the start of the motor symptoms. And about 60% of patients will require a wheelchair after 5 years. And the median time before the patient is bedridden is about 6 to 8 years. And at the end of the probable MSA stage, the patients might have a sudden death at night. So there will be a very important thing both the patients and physicians will care about is the prognostic factors. So there will be 2 parts. If the patient is older age at the onset and with the MSAP type, and also with the severe autonomic failure at the early stage, then we will see that the patients will have a negative prognosis. And then if the patients will diagnosis by as the MSAC type and with later onset of autonomic failure, then we can see that the patients will have a positive prognosis. And then we'll talk about the diagnosis of MSA. The diagnosis, we have 3 levels: the definite MSA, probable MSA, and possible MSA. Actually, the diagnosis of definite MSA is not possible until the patient died, because we should do the post-mortem examination of the patient's brain. Here is the probable MSA. So it's a sporadic progressive disease in adults, which should be older than 30 years old, and will have the autonomic failure, including the urinary incontinence or an orthostatic decrease in blood pressure, as we mentioned above. And the patient should have one of the following. The first one is the Parkinsonism. It's MSAP type, and also the patients or the patients can have the cerebellar syndrome, also the MSAC type. And then the possible MSA diagnosis criteria, it is more complicated. So possible MSA is also a sporadic, progressive, and adult onset disease characterized by the following. The first, the patients should have at least one feature of autonomic dysfunction as the incontinence, erectile dysfunction mentioned above. And second, the patients should have the Parkinsonism or cerebellar syndrome. And third, the patient should at least have one additional features as mentioned here. The additional features will include the possible MSAP or the possible MSAC, like the Babinski sign or stridor, or rapid progressive Parkinsonism, poor response to levodopa, and recurrent falls within 3 years after the onset of motor symptom. And lots of the additional features will listed here. And we should also notice that there are several features supporting or non-supporting the MSA. I think we should pay more attention about non-supporting features, such as the classic pure rolling rest tremor and the clinical significant neuropathy. And also here, the onset after age 75 years old and family history of ataxia or Parkinsonism and dementia, and also the white matter lesion suggesting multiple sclerosis. These should be noticed that it's no supporting features of MSA. And for the diagnosis, here are the image features by MRI, and most of them are typical MRI features of MSA. Through the picture one is the atrophy of points and cerebellum. You can see the fourth ventricle is dilated here. And then picture two is the hummingbird sign here. It is caused by the atrophy of the midbrain tegmentum. And the picture three is also the typical MRI features of MSA, the cross sign in points here. Then we can see the picture four. It's putaminal changes at both sides. We could see the hyperintense rim here, and the putaminal hyperintensity compared with the globus pallidus. And we can also see the picture 5, it's a MCP sign. It's the atrophy of middle cerebellar peduncle. And also here is a SPECT, picture 6 here. The right side of the picture shows a normal stratotracer uptake in PD patient, and the left side of the picture reviews the reduced asymmetric strato uptake in MSA patient. The last is the principles of therapy. Actually, there is no useful therapies for the MSA patients. So only symptomatic therapy is available at present. Unfortunately, the evidence level is low for these approaches. And the multidisciplinary management is recommended to optimally address the patient's needs. For the patients diagnosed as MSA-P type, we should know that although the poorly responsive to levodopa, there is still up to 30% of patients will have the transient beneficial response to levodopa. So a low increase in levodopa dose is advisable to minimize the exacerbation of orthostatic hypotension and edema and the nausea. In patients diagnosed as the MAC type, there is no specific therapy available, but the clonazepam may relieve the myoclonus or action tremor in MSA. There is also some complementary neural habilitation can be helpful in preventing the choking and falls, in augmenting the general coping and communication abilities. And here are the references. And thank you. That is my presentation.